I've been a practicing physician for a good part of my adult life, and I've worked in hospitals, but I've also worked in clinics in Rwanda and Haiti and Peru and even the former Soviet Union. So having been in that context of actually caring for patients in so many different settings, what I know is that every single system that I've worked in has enormous inefficiencies, things that you just can't believe are done in that way, but are indeed done in that way. And it's not limited to the poor country settings. And in some very poor country settings, the clinics worked a lot more effectively than some of the best hospitals in the country that I've also worked in. So for me, the fundamental insight was that while we were spending so much money and so much time trying to make new discoveries in basic science and also come up with new drugs and new treatments, we were spending almost no time trying to tackle directly the complexity of the human problem of delivering health care. Should it be a hospital? Should it be community health workers? Were the barefoot doctors in China the right answer to their problems, or was the hyper-privatized system that they later built the right solution to the problem? This conversation was really only happening in the most informal way. Health policy is something we've spent a lot of money on, but I came to the realization that health policy is really only one part of the equation. You can change the rules, you can change the way things are being funded, but it doesn't necessarily dictate the actions that happen. And also, the other thing we realized is that often you change policy thinking a certain behavior is going to result, and what happens is that physicians, especially in the United States, have gamed the system so that they maximize their financial return and didn't really improve health care. I think the fundamental insight for me then was that if indeed, as we have seen as I have seen in every country that I've ever worked in, that the real rocket science in healthcare is how you organize human beings to actually deliver what we already have and be prepared to deliver that which will be new, which will come down the path inevitably. We need to start studying it with some seriousness. And so I looked across the country, and I didn't find a single medical school that was actually teaching the enormous complexity of healthcare delivery to their medical students. And so what happened was medical students, just like me, would come out of medical school, go into a hospital, see all these inefficiencies, but then sort of be told, well, it's that way because it can't possibly be any other way. And so a few years back, I started working with people at Harvard Business School. Michael Porter was the first person that I worked with, and I still work with him very, very closely. And then I also started working with the systems engineering department at MIT. And they began giving me insights into how their own fields, their own areas of expertise, could have an enormous impact in healthcare. Basic things like management science and operations and strategy and leadership, things that in the business world are taken for granted, that you've got to do this right or you go out of business. Right. In the social sector, hospitals haven't been going out of business. Hospitals continue to run with negative balance sheets. And what's happened in the past is that physicians and hospitals have just found ways of enhancing their revenue so that they can keep operating in these very inefficient ways. So in this case, we stepped back and asked ourselves, so who's going to really make the difference here? One of our trustees is the CEO of United Healthcare, and she, of course, has an enormous stake in lowering cost and improving quality of healthcare. But she is a for-profit insurance company, and for them to stand up and say, here are 10 ways that you can lower healthcare costs, it would be very difficult for them to do it because they'd be accused of profiteering. Businesses that also support the healthcare costs of their employees, if they started talking about ways of cutting costs and improving quality, again, they'd be accused of having nefarious objectives. Mm-hmm. Therefore, it's critical that academics, that in higher education, do the kind of research and make the kind of bold statements about ways of cutting costs and improving quality that only we can make. I mean, we are the neutral party with the research capacity to come up with the kinds of insights that will help us move in the right direction. I mean, right now, we're moving in a completely unsustainable direction. The estimates are we're probably at 2.5 trillion expenditures today, and the estimate I saw was 4.4 trillion by 2018. Now, the most interesting thing about projections and healthcare expenditures is that if you look back 10, 15, 20 years, every time a projection's been made, it's been too low. It's been too low. So if we're going to go higher than that, over time, my goodness, somebody needs to be able to stand up and say, here's a much better way of doing it. Let me give you an example. There are places in the world, India, for example, where they've come up with extraordinarily interesting ways of cutting costs and improving quality. And if someone from United Healthcare stood up and said, hey, we've got something from India that we're going to incorporate at United Healthcare, that would be so difficult for them to do it. Now, I think the private sector has an extremely important role to play in taking the insights that we have, things that we find that can really be very effective in lowering costs and improving quality, and then scaling them up. Because my own sense is that that the private sector is going to have to play a critical role in helping us take those things which really will save money and really will improve quality and make them scale quickly. And my sense is that because so many companies are paying so much money for the health care of their own employees, that they will be willing to partner with us very quickly. Mm-hmm. There's good news, though, and the really good news is that we've got plenty of insights. There's plenty of examples out there of people who've provided much higher quality of care at very low cost, sometimes 30, 40, 50% lower cost than the average in the United States. What we need to do now as an academic institution, partnering with many other academic institutions, is to begin to study those, package those ideas, and begin to teach them to people who are going to be able to implement those changes.